We saw the obturator nerve last class, isn't it? That's where we stopped.
Yes, sir.
Okay. So we go to the next one. Now what is shown here? It's an ultrasound picture of an area.
Suprascapular nerve block.
Suprascapular nerve, good, correct. The ultrasound image of the suprascapular nerve. If I have seen the trapezius muscle, you have the supraspinatus muscle, this is the suprascapular artery, this is the suprascapular nerve, and this is the, what is STSL? Superior transverse suprascapular ligament. Okay, so name the structures shown. I have already told you the trapezius muscle, supraspinatus muscle, suprascapular artery, suprascapular nerve, and superior transverse scapular ligament. Okay, these are all the structures that are there. Now, what is shown in this picture? Person is keeping a finger and then putting the probe over that. What are they trying to show? Media.
Yes, sir.
So the finger under the transducer imitates the direction in which the suprascapular nerve runs. So the transducer aims to capture a transverse view of the nerve. Okay. What is the anatomy of suprascapular nerve? Where does it arise from? How does it run? So what is the ultimate destination?
It arises from C5 nerve roots.
C5 nerve root level at the brachial plexus, isn't it? There are branches arising at the root, trunk, and level. Is it root or trunk?
Root C5 root, sir.
Hmm.
C5 C6 nerve trunk. Yes, sir.
Arising from the superior trunk, not root. Okay,
Yes,
it is a root value is C5 C6. So it's C5 C6 combined to form the superior trunk. The C7 runs as a middle trunk, and C8 and T1 form the inferior trunk. So it is a branch from the superior trunk with a nerve root of C5 C6. Often it may receive a contribution prefixed by C4 nerve root as well, and passes underneath the omohyoid muscle in the posterior triangle of the neck. Okay. Then it passes posteriorly towards the scapula together with the omohyoid muscle towards the suprascapular notch. And the nerve passes deep to the superior transverse scapular ligament. That is why this is also has been mentioned here. So it goes, the nerve goes under the scapular ligament, and the artery and vein, they go above the ligament. That is a very important anatomical landmark that you should know. And at the notch, the nerve is next to the suprascapular artery and vein, but the vessels pass above the ligament and nerve passes below the ligament. Now, what is shown in this picture? This is a continuation of the same question. In this picture, in the inset, you can see where the probe is being, this is the jaw, this is the shoulder. So this is from the front. So what are they trying to do?
Supraclavicular.
Supraclavicular. I told you this is a
Can
continuation
we
of the same question from the earlier slide. So it is only about suprascapular
tracing
nerve.
from the brachial plexus trunk?
Pardon?
Tracing the origin of the nerve.
Anterior approach. This is called the anterior approach. Suprascapular nerve can be blocked both from the posterior aspect as well as from the anterior aspect. So blocking the suprascapular nerve in the posterior cervical triangle. Just now in the anatomy we saw it runs through the posterior cervical triangle along with the omohyoid. So you can block the nerve from the anterior aspect also. Now you have the short forms. What are all the nerves and the structures that are marked there?
Subclavian artery, inferior omohyoid.
Inferior. Very good. Arrow shows the suprascapular nerve, inferior belly of omohyoid muscle, subclavian artery. Now, what are the techniques of blocking the suprascapular nerve? I already told you the answer.
Anterior approach.
Anterior and posterior.
You have a landmark based posterior approach and an ultrasound guided anterior approach. What are the indications for suprascapular nerve block?
Shoulder surgery.
Shoulder surgery, very good. So, can be used for chronic, acute, and perioperative shoulder pain. That is number one. Post trauma or shoulder surgery patients. What are the complications of suprascapular nerve block?
Phrenic nerve palsy.
My God, phrenic nerve palsy is absent. That is why this is the preferred technique in patients where you don't want phrenic nerve palsy. Because shoulder surgery, normally we prefer interscalene approach, isn't it? And
Yes, sir.
intrascalene approach has got the risk of phrenic nerve palsy.
100%
So
phrenic
if
nerve
you
palsy.
don't want phrenic nerve palsy, you have to go for suprascapular nerve block. So phrenic nerve palsy can be avoided by doing SSN block. Okay. So accidental intravenous or intraarterial injection. I told you a suprascapular artery and nerve are going above the ligament. The nerve is going below the ligament. So you may mistake the artery and nerve for the nerve and inject there. So that is one complication. Pneumothorax is a potential complication in the anterior approach, and infection, bleeding, local anesthetic toxicity, nerve injury are all general complications of any nerve block which can happen here also. So please don't mention phrenic nerve palsy here. This is
Yes, sir.
important. Combined with what other nerve block can be combined for a successful shoulder surgery? Is suprascapular nerve alone enough?
No, so superficial cervical
Cervical
plexus.
plexus.
No. Superficial cervical is not needed. Once you give suprascapular nerve, you have to block another nerve for an effective upper arm surgery or a shoulder surgery.
Axillary nerve.
Axillary nerve, yes, exactly. You have to do axillary nerve block also. Now the next thing is, during a serratus anterior brain block, the clinician is concerned they might have pierced the structure indicated by an arrow. What sonographic sign would be reassuring? How the
Lung slidings.
lung sliding. The mid-axillary line to intercostal space indicated to operate left. So lung points, lung sliding, A lines, and posterior acoustic shadow. Okay, all these things should be reassuring that you have not caused a. What muscle is shown here and what is its origin and insertion?
Serratus
Serratus
anterior.
anterior.
From lower 8 ribs.
So the origin is upper 8 or 9 ribs. The insertion is medial border of scapula. Okay, so they arise from the upper 8 or 9 ribs, not the lower. Starting from the upper 8 or 9 ribs, they all go and attach into the medial border of scapula. How many potential spaces are formed by serratus anterior muscle?
7.
Spaces.
8.
2 spaces.
8 spaces, because 8 origin. 2 spaces, superficial and deep. Okay, so there are only 2 potential spaces. One is superficial, another is deep. What are the boundaries of these planes or the spaces? At the level of fifth rib, the superficial plane forms from the anterior aspect of serratus anterior and the posterior aspect of latissimus dorsi muscle. That is one plane. The deep plane forms from the posterior aspect of the serratus anterior and the external intercostal muscles and ribs. So there are 2 spaces only. The upper superficial is between the latissimus dorsi and the serratus anterior. The deep This is between intercostal and serratus anterior. What are the indications for serratus anterior plane block?
So for breast surgeries,
Surgery. So effectively for the management of pain in the context of rib fracture, rib contusions, thoracoscopic surgery, thoracotomy, breast surgery, and post-mastectomy pain syndrome. So these are all the indications. What are the two devices shown here? Are they both same or different?
So,
different.
That is why two pictures are seen. So they are Basca mask, red color, and Basca fest mask, green color. Okay. So both are called Basca mask. The red color is called ordinary Basca mask. The second is called the Basca fest mask. What are the parts of this device?
So it has two parts. One is ventilatory port and the other one is gastric port.
Hmm.
Non-inflatable cuffs.
Hmm.
No need of bite block. It has an
Incorporated bite block is there. What is this portion? This something like a tongue projecting here. Are you able to see that?
Yes, sir.
Yes, sir.
What is that for? So these are all the parts that you have to see. Okay, attachment for suction to keep the sump area clear, suitable for placement on either side. This is the leave open to atmosphere for air to enter. So there are three channels. This is the ventilating channel. This is the channel for air entry so that the suction does not cause a collapse of the pharynx or stomach. And this is the bite block. This is the what is called the insertion tab for manually curving the mask for easy insertion. You can just pull it and make the tip bend in case when you find it difficult to insert. This is the advanced airway opening, this one, and self-recoiling cuff. So the cuff will automatically position itself. You don't have to inflate it. Advanced self-sealing variable pressure cuff. There is another advanced self-sealing variable pressure cuff, and superior gastric reflex drainage port. So these are all the parts that you have to mention here. Under what category this airway comes? Category of LMA. Which category? First generation, second, third,
Three
fourth,
generations.
second or third generation supraglottic airway device. What is the OLP of this device? What is OLP? Oropharyngeal leak pressure is 26 to 30 centimeters of water. Okay, that is the OLP or oral pharyngeal leak pressure surface. Another ultrasound question. What is shown here?
ultrasound of the airway showing the cricothyroid membrane.
Cricothyroid membrane. Very good. Ultrasound anterior US guided airway examination to identify cricothyroid membrane. What is the probe that is being used for this examination?
Linear probe, high frequency.
Correct. What is the view? How do you describe this view?
Sagittal view of the trachea.
Sagittal.
Sub-
Sagittal means across. Longitudinal midline view. Okay. What other information can be obtained by ultrasound of the airway?
So skin to epiglottis distance,
Hmm.
size of tongue,
vocal cords.
It can visualize
presence
anatomical
of ET
structures
tube
in
in
the
the
supraglottic, glottic, and subglottic regions. The floor of the mouth can be visualized by transcutaneous view of the neck and by transoral or sublingual views. Other applications are confirmation of correct endotracheal tube placement, evaluation of soft tissue masses in the neck prior to intubation, assessment of subglottic diameter for determination of pediatric endotracheal tube size, and percutaneous dilatational tracheostomy. These things are the use. And prediction of post-extubation stridor also can be done using this. What surgery is being performed?
TUR, urological procedure, probably TUR.
QRP.
Very good. What type of PRP? Is the surgeon looking through his resectoscope or is he not bending and watching through the resectoscope? He's watching only the monitor, isn't it?
Monitors.
Surgeon.
Yes.
Yes, sir.
So TV monitor assisted TURP. Earlier they used to look through the resectoscope, bending their head and neck and then struggling to see with the eye on the eyepiece of the instrument. Now this has become much more easier. They can visualize that. So how do you manage TURP syndrome?
Fluid
It depends on the serum sodium level and the patient symptoms, sir. So usually it will be resolved by restricting the fluid and giving diuretics.
Very good. Supposing sodium is very low, how do you correct it? What fluids you can give to correct it?
0.9% NaCl or 3% NaCl is used, sir.
Any other solution?
Glycine.
Glycine. Glycine given IV. Glycine is
Mannitol.
used for resection. Correction of sodium. Sodium bicarbonate can be given. Sodium bicarbonate also. So the steps in management of TURP syndrome: notify the surgeon and stop the surgery. Restrict fluid. If pulmonary edema is present, intubate and give IPPV. Bradycardia, hypertension, give atropine adrenergic agent. If there is seizure, benzodiazepine, thiopentone, phenytoin, IV magnesium. Invasive monitoring, arterial CEP, send blood sample for electrolytes, arterial blood gases. And then what are the complications of this surgery?
TURP syndrome, bleeding,
Bleeding, bladder
Pulmonary
perforation.
edema, bladder perforation.
So intra-op, early post-op and late post-op, like that you can classify. Intra-op, hemorrhage, urethral injury, bladder injury, TUR syndrome, mortality. Early post-op, urinary retention, clot retention, urinary tract infection, epididymal orchitis, septicemia, DVT, pulmonary embolism. Late post-op complications, because most of them are all surgical oriented. So what is alveolar gas equation and what is its importance?
It is
alveolar
used to calculate alveolar and arterial gradients.
Gradient, very good. Alveolar gas equation helps you calculate the oxygen tension in the alveoli by using the formula PaO2 is equal to FiO2 into the atmospheric pressure minus saturated vapor pressure of water minus PaCO2 divided by respiratory quotient. So alveolar oxygen tension determines the partial pressure gradient driving oxygen across the alveolar capillary membrane. It is also used to determine the AA gradient. What do you mean by shunt?
Bypass.
The percentage of blood which is not oxygenated.
Oxygen.
Bypasses the
Deoxygenated
ventilation.
blood refers to the portion of blood not taking part in gas exchange. What is the physiological shunt and where does it occur?
One is through the Thebesian veins. They
Ah.
drain directly into the left atrium, sir.
Very good. Thebesian veins were draining which one? Which part of the body? Which part, heart or trachea or
Coronary.
coronary? Yes. And drainage of deoxygenated blood from bronchial circulation directly into the left atrium. Drainage of coronary venous blood directly into the left ventricle by Thebesian veins are called physiological shunts. Okay. What is pathological shunt?
Portion of blood not taking part in gas exchange because of atelectasis or any airway obstruction.
Can be cardiovascular or respiratory in origin. Okay.
Yes, sir.
Previous intra or extracardiac connection between right and left side. That is right to left shunt, isn't it? We always talk about tetralogy of Fallot. Okay. And respiratory prevention of oxygen passing through the airway to reach alveoli, like in pneumonia, ARDS, bronchial obstruction, or one lung ventilation. So these are the causes. Now shown here is the serial ABG values of a patient in ICU after CABG. What is the diagnosis? I think from 0 hours, every 4th hourly is being measured with all this pH is there, sodium, potassium, bicarbonate, chloride, blood glucose, lactate, all these things are there.
Metabolic acidosis.
Metabolic acidosis. What about the lactate? Why they have mentioned lactate here? And what about the glucose value? Is it normal or abnormal?
Initially it was high, sir.
0 hours, it is only 176. And it has gone to 210 only at the 12th hour and again come to 133. So more or less acceptable value. Less than 200, you can say it is not very severe hyperglycemia. But lactate levels are quite high, isn't it? Comes back to 1.4 at the late level. PCO2 is also quite acceptable. So it is not respiratory. Bicarb is consistently low. Coming back to normal only here. So, euglycemic ketoacidosis. Okay, diabetic ketoacidosis. What are the causes of euglycemic ketoacidosis?
Stress.
Causes.
Stress.
Stress.
Surgical stress.
Surgical stress. Then only one.
Starvation ketoacidosis.
Supposing a diabetic patient is treated with a particular anti-diabetic agent, can it cause euglycemic ketoacidosis?
SGLT2 inhibitors, sir.
SGLT2
SGLT2. Treatment with SGLT2 inhibitors, which are now very commonly prescribed by most diabetologists because of its additional advantages compared to not only the control of blood sugar, it also has some good cardiovascular effects. So they use this very commonly nowadays. And restricted calorie intake patients who don't take calorie, surgical procedures, abstinence from food or starvation, and physiological state of pregnancy also can produce euglycemic ketoacidosis. Inflammation of pancreas, acute pancreatitis also can produce, and prolonged or severe episodes of vomiting or diarrhea. All these things are the causes of euglycemic ketoacidosis. How do you treat this condition? Is it any different from the treatment of diabetic ketoacidosis?
It is self-resolving, sir.
It's almost similar to DKA treatment. You have to correct the dehydration and you have to correct the acidosis. So treatment of dehydration by administering intravenous fluids, continuous infusion of insulin until the acid-base balance normalizes, which is reflected by closing of the anion gap and the return of bicarbonate levels to normal range. And close monitoring of blood electrolytes, ketone levels, and ABG is crucial till the values return to normal. Okay, so if you see here in the 30th hour, all the parameters have become more or less normal. pH has become normal, sodium normal, potassium normal, bicarb normal, chloride normal, CO2 normal, PCO2 normal, lactate has reduced to less than 2, and glucose has come to 133. Okay. What is the
Antifibrinolytic
Ampule
tranexamic.
ampule of tranexamic,
the
which is
synthetic
an antifibrinolytic.
lysine analog, which inhibits fibrinolysis, promotes clot stability, and may reduce inflammation? Okay. What are the indications for its use?
In surgeries where blood loss more than 500 ml is expected, sir.
Only one indication.
Obstetrics also.
Menorrhagia.
Yeah. Administered to medical, elective, and emergency surgical patients, reduce their bleeding and transfusion requirements. What is the mechanism of action?
It
How does it
inhibits
act?
plasminogen activation, sir. So it causes
A reversible competitive inhibitor to the lysine receptor found on the plasminogen. Okay, so plasminogen has to be converted to plasmin, which will be activated only by lysine receptor. So the binding of this receptor prevents plasmin, activated plasma plasminogen, from binding to and ultimately stabilizing the fibrin matrix. So if you see this picture, this is the normal course of events. This is plasminogen, this is tissue plasminogen activator. So this has got to bind to the fibrin to stabilize the fibrin. Okay? And then later on, the fibrin has to be degraded. So this is the function here. When you give tranexamic acid, it goes and occupies the lysine receptor area analog. Because it structurally resembles the lysine, it goes and occupies that. It prevents this binding. So fibrin does not become strong enough. It gets degraded much more easily. What is shown here?
Thromboelastograph.
Elastograph of which condition?
increased clotting.
Increased clotting means this version should become narrow.
Fibrinolysis.
The tail is very long. Okay, so this clot strength is okay, the clot activation time is okay, and the tail only is getting prolonged, which is the fibrinolysis time. Okay, so here text showing fibrinolysis. What are the contraindications for use of tranexamic acid? Which conditions you should not
History of
use tranexamic?
History of
Patients?
thromboembolism.
Huh?
History of thromboembolism. Seizure.
Known allergy, intracranial bleeding, known defective color vision patients, history of venous or arterial thromboembolic patients. Okay? In all these conditions, it should not be used. What is the drug shown here?
SGLT2 inhibitor. Sir.
SGLT2 inhibitor. It's an anti-diabetic drug belonging to SGLT2 inhibitor. What is the mechanism of action of this drug?
It
Inhibits the
inhibits the
glucose transport.
reabsorption of glucose from the kidneys.
facilitates glycemic control by inhibiting renal glucose reabsorption, thus promoting glycosuria. Their unique mode of action is independent of beta cell function. In addition to glycemic effects, their extraglycemic cardiovascular benefits include weight loss, reduction in blood pressure, and a decrease in cardiovascular deaths. What are the side effects of this drug?
UTI and euglycemic ketoacidosis.
Very good. Mild increase in frequency of urination and dehydration, dizziness, fungal infection in genital area, serious complications, hypoglycemia, and euglycemic DKA. So this is the mechanism of action. You can see the plasma glucose getting filtered in the kidney, and this prevents the reabsorption filtered. So glucose get excreted, and the pancreas, it blocks the effect. The plasma insulin level decrease, then it helps in the tissue weight loss. Adipose tissue conversion is reduced, and the mitochondrial level, it acts on the CoA and acts on these things for the effects. What pre-op advice to be given regarding this drug? When
The drug
the
should
drug
be
be
stopped
continued, or
at least 48 hours prior to surgeries.
ideally stop 3 to 4 days prior to surgery to prevent euglycemic DKA. This is the scalar seen in a ventilator. What is the mode of ventilation?
Assisted pressure ventilation.
Said,
Pressure support ventilation.
Pressure
pressure
control.
support, spontaneous. Is the patient triggering the ventilator or not?
Yes, sir.
Yes, sir.
You can see the negative deflections here. Okay, so patient is triggering. The patient triggered the support is a limited mode. Can be called as pressure support ventilation. What is the indication for this mode?
Stepping down from
Weaning from mechanical
Weaning
ventilation.
from ventilator. Very
like weaning.
used during weaning from mechanical ventilation without disconnecting the patient from the ventilator. What was the earlier method of weaning?
Wait, sir.
T-piece usage.
T-piece mode.
T-piece, yes. Patient used to be disconnected from ventilator but remain intubated and allowed to breathe spontaneously through a T-piece support. What is failed extubation?
So 3 or more spontaneous breathing trials ended up in failure.
We have to
Patient
re-intubate after 48 hours due to failed.
24 hours. Okay. If a patient is re-intubated and connected back to mechanical ventilation within 24 hours of extubation, it is called failed extubation. What is shown here? The patient who is anesthetized, and you can see some electrodes being placed here. Huh?
No,
Bis
entropy,
monitor.
sir. 3 electrodes.
Entropy or BIS, some depth of anesthesia monitoring is being done. It may be entropy. What is entropy? Now that you have told entropy, what is the meaning of the word entropy? The measure of irregularity in any signal. Now here we use the EEG signal. So we measure the irregularity in the EEG signal. Okay? So the word entropy means measure of a irregularity in any signal. So what are the types of entropy?
Read only and sensory.
RE and ST.
RES.
RESC. What is RE? What is SC?
Response entropy, state entropy.
Excellent. Response entropy and state entropy. Very good. What are the characters of response entropy and state entropy? From where, which part of the body you get the response entropy when you apply the electrodes there?
The brain.
Cortical areas.
Cortical. State entropy consists of entropy of the EEG signal calculated up to 32 Hertz. Response entropy includes additional high frequency up to 47 Hertz. So the fast frontal is EMG, okay, because it is applied onto the forehead. There is a muscle called frontalis muscle here. Okay, so the fast frontalis EMG signals enable a fast response time for response entropy, whereas the state entropy takes the EEG signals up to 32 Hertz. Okay. What display will be seen when the entropy monitor is switched on? What is the first signal you will
The
get?
two parameters RE and
Immediately you will get that. Have you seen an entropy monitor?
yes, sir.
Huh?
Yes, sir.
Yes, sir. Then when you switch it on, will you immediately get the RE and SE display, or will you get
It
something
calibrates.
else? First the sensor check will be shown. So the sensor check panel passed. This 3 ticks will come. Next values of RE and SE and BSR percentage will be displayed like this. So RE 14 and SE 10. What is BSR? Any idea? It's called burst suppression ratio. Burst suppression ratio. What is the display range for RE and SE? From what starting point to end point? Display range. Is it same
0
like
to
this?
100.
So for RE it is 0 to 100. For SE it is 0 to 91. Okay. So parameters, response entropy, you get 0 to 100. State entropy, you get 0 to 91 because the frequency rates are which is lower for SE. What are the values at various depths of anesthesia displayed? You use the entropy monitoring. What will be the value if the patient before induction?
191. Response
90 to
100.
100. Okay, for a state it will be 91, for a response it will be 100. Okay, then patient will be having low probability of recall at the 60 value and clinically adequate level of surgical anesthesia at 40. Below 40 it will become deep anesthesia. At 0 it will be suppressed or flatline EEG. Okay, so this can be used as a part of brainstem testing also. So if you put this monitor and you get a value of 0, that means there is no electrical activity in the brain. So this can be used as a part of brainstem death confirmation also. What is seen in this? One of the history questions. We celebrate a day for this every year.
Ether, sir.
Ether inhaler.
Ether.
The ether
Yes, sir.
inhaler used by Dr. Martin to demonstrate ether anesthesia. Why? You can see here it is called lithium inhaler.
Lithium.
Why is it called the lithium? Martin named this inhaler as lithium because in Greek mythology there was a river called Lethe, which removed all the painful memories. So he named it after that Greek river called Lethe as a lithium. What is written on Martin's tombstone as a praise for his contribution to anesthesia?
Something about pain is inevitable.
Surgery was painful unless
It's a very
Something about
beautiful quotation. Before whom in all time surgery was agony, by whom pain in surgery was averted, since whom science has control over pain. Very beautifully written. Before whom, in all time, surgery was agony, because they used to physically restrain the patient, and without any pain relief, they used to operate. And the patient shouting, yelling, trying to release himself, kicking about. By whom pain in surgery was averted, and since whom science has control over pain. And this is the another thing, epitaph on this tombstone. Discoverer and demonstrator of ether anesthesia, notable contributor to the advancement of surgery. First public demonstration at the Massachusetts General Hospital on October 6, 1846. He was born in 1819 and died 1868. So hardly lived for 49 years only. Where are these formulae used? You have three gases, two gases and inhalation anesthetic agent. You are given three formulas here, and you are given some remarks on why these formulas are being used. So from this clue, what do you think, why these formulas are there?
How much of the gas is being consumed, used up from the
Where do you apply this formula? Your answer is right. You are finding out how much is being consumed, but why do you want to know how much is being consumed? So they are used during low flow anesthesia to find the uptake of gas. Okay. What is low flow anesthesia? How do you define low flow anesthesia?
Less than
fresh gas?
500 ml.
500 to 1 liter.
If the fresh gas flow is less than 250 ml, then it is
Less than 500.
500 to 1 liter.
So it is based on the volume that you use, right?
Yes,
Or
sir.
it
When
is
the
some
fresh
physiological parameter. Any technique using a fresh gas flow less than alveolar ventilation is called low flow anesthesia. It may vary from patient to patient and condition to condition, isn't it? So there is no fixed value like 250 ml, 500 ml or anything like that. It is less than alveolar ventilation. So any technique using a fresh gas flow less than alveolar ventilation is called low flow anesthesia. What flow rates are used during anesthesia and how are they named? Based on the volume or the
high flow is when we use fresh gas flow of 6 to 10 liters. So
10 liters. 10,
6 to 8 liters.
6 to 8 liters. Medium flow, low flow, metabolic
Medium flow
flow.
is a 1
There are
liter
so many words.
fresh gas flow, sir.
You must read well about low flow anesthesia. It's one of the important topics that may be asked in the Viva as well as in theory questions. Okay. So
Yes, sir.
any flow rate less than 0.25 liters per minute is called metabolic flow. 0.25 to 0.5 liters per minute is called minimal flow. 0.5 to 1 is called low flow anesthesia or low flow. Medium flow is 1 to 2 liters. High flow is 2 to 4. Very high flow itself is only more than 4 liters. Okay, so these are the various classifications. What are the advantages of low flow anesthesia?
conservation of gases
Very good.
Temperature
maintains the
maintenance.
humidity and temperature.
Over pollution will be less.
Excellent.
Plus
Very important
environmental
point.
pollution.
Global warming or pollution. Excellent. Okay. So it can be classified as physiological, economical, ecological, environmental. This is how we must classify. Physiological preserves heat and humidity of inspired gas, thereby conserves body temperature, reduces water loss, improves flow dynamics of inhaled anesthetic gases, increases mucociliary clearance, improves airway epithelial health, reduces accumulation of dried airway secretion. These are all the physiological. Economical, reduces anesthetic gas consumption, significant savings to the order of 60 to 75% of volatile anesthetic agent. Ecologically, reduced overflow of fluorocarbons and nitrous oxide, which damage the Earth's ozone layer, reduced greenhouse effect due to nitrous oxide and volatile agent. Environmental, reduces operating room pollution since less exposure to anesthetic vapors during cooling. And what is Gothenburg technique of low flow anesthesia? Have you heard of this terminology?
No, sir.
No. So when you start the induction, for 6 minutes you give oxygen 1.5 liters per minute to nitrous oxide 3.5 liters. Then after that you start maintenance phase where you reduce the oxygen to 4 ml per kg per minute. And nitrous oxide adjusted to maintain constant oxygen concentration in the circuit using oxygen analyzer. Okay, this is called the Gothenburg technique of low flow anesthesia. A 24 years old primee undergoes an emergency, delivers a live female baby, but uterus is not contracting after placenta has been removed. Patient has lost about 750 ml of blood, her pulse is 92, BP 104 by 96, capillary refill time is 3 seconds, patient conscious. So under what class of hemorrhage the patient is in now? What are the steps to stop further bleeding?
Class 2, sir.
Very good. How do you say it is class 2? What are the things to say it is class
The
2?
blood loss more than 500 ml.
Okay, very
Blood
good.
loss is in between 15 to 30%. Capillary refill is positive. Narrow pulse pressure.
Very good. And diastolic pressure is increased. So patient is conscious, mildly tachycardic, diastolic BP is high with narrow pulse pressure and increased capillary refill time and blood loss 750. All this indicates he is in class 2 hemorrhage. And the steps that you have to follow is ask for help, assess the pressure state. It is a mnemonic hemostasis, which you can remember. Hemostasis and all these things, tamponade, balloon thing, all these things all of you know. What are the causes of postpartum hemorrhage?
4 T's, sir.
4 T's. Stone, uterine, tissue, trauma, and thrombin. Good. What is defined as massive obstetric hemorrhage? What are all the criteria to say there is a massive obstetric hemorrhage? Blood loss more than 1500 ml or a decrease in hemoglobin of more than 4 grams per deciliter for the baseline, acute transfusion requirements of more than 4 units. All these things say is what is MOET and what is also and what are its uses? Okay, there are courses such as managing obstetric emergencies and trauma and advanced life support in obstetric, which are useful in training all involved in management of obstetric emergencies. What is methylene blue and what is its unique property?
It is 100% excreted in urine.
100% excreted in urine. Okay.
It's in
So it is
biological
an
dye.
aniline dye derivative. First part of the question, what is methylene blue? It is an aniline dye derivative. It is first a totally synthetic compound used for medicinal purposes. First a totally synthetic compound. What is its chemical name? Even though it is commonly called as methylene blue, what is its synthetic chemical name? Generic name. It is called methyl thiominium chloride. Methyl thiominium chloride. What are its physicochemical properties and its formula. Of course, formula you won't remember, C16H18CiN3S, heterocyclic aromatic thing. What are its physical properties? Is it available ready-made as a liquid, or is it a powder which is converted into liquid?
It's available as a liquids.
Liquid is marketed in ampoules as liquid, but is it manufactured as a liquid directly? It's an odorless dark green powder which yields a blue color liquid on dissolving in water. Okay, so it is manufactured as a powder form, then it is dissolved in water and then marketed in ampoules. What are its uses in anesthesia and intensive care?
It is used as an indicator in
Indicated in?
Used as an indicator in several procedures.
Indicator dye. Okay. You can use it for identifying a vesicovaginal fistula or a tract in a cyst in the bronchial cyst. Okay.
Any leak or rupture. Yes, sir.
Right. Okay. You can use it in the cuff of laser tube, which we just now saw. Then any other intensive
for
Treatment in cyanide
treatment.
poisoning.
antidote for
Cyanide.
Local anesthesia toxicity.
methemoglobinemia. Treatment of methemoglobinemia. It acts as a vasopressor. It is used in septic shock. Can be used in anaphylactic shock. Orthotropic liver transplantation. Cardiovascular poisoning with amlodipine. Ifosfopamide toxicity treatment. Hydrogen sulfide toxicity treatment as an indicator dye. These are all the things. What is the ifosfopamide used for? Any idea? Ifosfamide. What is it used for? Is it a... Okay, tell me in the next class. What is vasoplegic syndrome and what are its features?
Where the blood
it's a
vessels
common
does
complication
not
after major cardiovascular surgery. Features are mean arterial pressure less than 50, cardiac index less than 2.5, right atrial pressure less than 5, left atrial pressure less than 10, and low SVR. How does methylene blue help in septic shock? This is one of the important critical care uses. What happens in septic shock? Why is the BP low?
because of vasodilation.
Vasodilation. So what drug we commonly use?
Noradrenaline.
Noradrenaline. If noradrenaline is going to be not helpful, then you use methylene blue. Why? Because inhibition of guanylate cyclase induced methylene blue infusion reduces nitric oxide production. So nitric oxide is a vasodilator. So if you block the production of nitric oxide, it improves vasoconstriction and helps in the fraction. Okay, so that's all for today. Right. As we close down.